last session, talking about why worksite centers fail and what are the signs or what are the landmines. So with that, I'm asked three individuals who have some great perspectives and background, both in their own organizations and in consulting with other groups, from what they've seen, long experience on all sides. So let me just start with Heidi. Would you introduce yourself, please?
Is this on? My name is Heidi Orsted. I'm a registered nurse clinical consultant, and I have the pleasure of working with Marcia McLennan, which is a broker. I support employers to help them understand their clinical data, and with that, I support several of my employers with their health, their worksite health clinics. Usually it goes really well, and sometimes not so well. So that's my perspective. Thank you.
Thank you, John.
So I introduced myself earlier today. Just going to tell a quick story. So Larry asked me to speak on a panel. I was very flattered. And then he asked me to speak on a panel for why clinics fail. So I tried not to look into it too much. I'm not going to read into that. That's okay. And then I saw the agenda. And we were the last speakers of the conference. So then I thought, well, I guess I need to change my flight. So I appreciate everybody who remained here, and we have a nice little audience for the last speaker.
I'm sorry, John.
Michael Bennett, I'm a consultant and from a small boutique consulting firm. That means very small firm. And we've been involved in on-site clinic development for 20 years. Originally we were in development, and now more often we're in transitions. And sometimes the transitions are abrupt and sometimes they're smooth. I hope that the people in the room here are not all contemplating transitions, because that would be a tragedy. But they do occur, and I'm glad we have this session. Again, it's the last session of the day. So we hope we have some spirited dialogue.
So Heidi, let's start out with you. We'll work our way around the table. What are the early qualitative warning signs that a clinic operation might falter or fail in some way?
You know, I think I'm maybe repeating what's been said before, but the first inkling that things are not going well is when there's a relationship issue with the provider. We might see with a trend that's very, very strong, switch out the provider, and we start to see the rates go down. We start to see the NPS score go down. We look at the comments, and we start to see that they reflect with that provider. So I think that's number one. The other qualitative issue is when there's provider turnover. I think that breeds distrust with the clinic. People go back out to the community. They figure, I don't want to build another relationship again. I'll kind of pass it over to John there. That's number one for us.
Yeah, and I think I'll start with, when we're talking about why clinics fail, it's pretty rare for a clinic to actually fail. I mean, you may see an employee population that completely changes from maybe 1,000 employees in an area, and you drop it to 10. Of course, the clinic's not going to be viable anymore. Or you have leadership changes, and the leadership doesn't buy into the on-site clinic. They've had negative experiences in the past, and they end up closing down the clinic. So I think really what we're talking here is about clinics that are struggling, clinics that end up having some major changes or turnover and better partnerships or that kind of thing. But certainly early warning signs are low utilization. If your provider isn't well liked, it's going to be really difficult to maintain that clinic viability. Low quality scores, just not doing a good job taking care of patients, end up having pretty poor referrals. If your employees are talking negatively about the clinic, it's not gonna bring in more people. And then I think just as you're looking at the viability of the clinic as a whole, you just need to make sure that you have access, availability, that benefit structure. If those things aren't in place, then that all shows up in some of those early warning signs with utilization.
And Mike, how about you? What have you seen that causes you to take a breath and say this clinic's in trouble?
Well, here at NAWHC, everybody's looking ahead at all the different trends and changes and possibilities, but sometimes people fail to look backwards and try to understand why they developed these clinics in the first place. So we see it sort of falling into four areas. One is a change in the employer status. That could be, as John mentioned, a radical change in the employee makeup or component that originally was the reason for the on-site clinic to be planned, or a change in the leadership, second, of the host firm. The vendor partner, secondly, can also change. We see this more often now with the private equity firms coming into being and changing dramatically sometimes the management structures of the vendor providers. The third is failure to achieve what the projections were, failure to report, lagging in reporting, failure of communications is the last. We often tell people that, the original slideshow that you looked at is not the contract that you signed, but the early warning type things that we see all fall into one of those categories. And I agree also with John, we very rarely, but we have seen situations where the clinic is abruptly closed without any kind of warning, although everybody will say there was warning. Most of the time there are transitional problems that if everybody works on it can be resolved.
So Heidi, let's talk about that. Are there signs like in implementation that you can see, because it's not just the vendor that fails, sometimes it's the employer that fails. Could you talk about that?
Yeah, I agree. And I think number one, I think you have to figure out what the data is saying and why you're putting the clinic together in the first place. Do you really need the clinic? I think you have to look at the population you're trying to serve. Are they near the clinic? Are they working from home? Are they in the field? Do they work hours such that they can access the clinic? Are there penalties if they use the clinic? So are you setting the clinic up to succeed in the first place? Are the KPIs identified early on? Are they reasonable? So I think implementation is key. We have a Worksite clinic consulting team, and so this is their bread and butter. This is what they do. They understand what the norms are. And so having that structure in place, we can set things, up for the client to succeed, and versus being driven by the vendor. So I think you're right. I think it has to be both the vendor and it's up to the clinic and the consultant to make sure it's set up well.
John, talk about the employer-vendor relationship here. What has to be done to make sure this doesn't happen?
Well, I think it goes both ways. So from QuadMed's perspective, we know that not every client is a right fit for us, and we're not a right fit for every client. We can't be everything to everybody, but what we do well, we want to do it really well for the right client. So we look in generations. Like I mentioned earlier, we are a subsidiary of a publicly traded, family-controlled printing and marketing solutions company. So that company's been around for over 50 years. We're on our 5th generation of employee going through our parent company. And so an ideal framework for our clients would be ones that look in decades or generations, not just in quarters. And so for us, that's where we want to make sure that we have the right fit, that we're going to have a long-term partnership. Clinics are going to have ups and downs. You're going to have, it's a little bit of a roller coaster ride sometimes. The providers sometimes come and go through no fault of anyone in the relationship there. So having that strong partnership between the vendor and the employer is key, because we're going to be able to walk through that together. We're going to have shared decision making and be able to manage this clinic. It's not that the employer is just asking the vendor to run a clinic. That's not the goal. It has to be a partnership long term for it to be successful.
So Mike, building on what John said, what should perhaps a vendor partner or hospital system look for in an employer to see that's going to be successful, as well as the employer looking at the vendor to be a good partner?
Well, the fit is important, as John said, because when we look at vendor partners and make a list or categorize them, we'll ask questions and we'll say, first of all, how far do you reach? How big are you? Where's your span of control? What are your what's your base of operations and your experience? People will give us their aspirational answer, not their real answer. So everybody's national, where they only cover 15 states. And then when we talk to the employers, what you're seeking, what you're looking for, they want cost control, and they don't remember that employee satisfaction, employee commitment, employee engagement are really what these clinics are all about. And that's more important than cost control, because the cost control only comes with programmatic and cultural change. So we look for the ability of the two groups to actually communicate on a real level, and not through, again, slideshows and PowerPoint and sales transactions, but at the real core. We're also looking for true commitment at the managerial level, at the true managerial level, not at the transactional purchasing department HR level. I'm not disparaging any HR people. Yeah, I guess I am. So we want it at the CFO or C-suite level, and then at the true management level of the partner that's going to be there, because we see these contracts now important to be on a long-term basis, and all of the things you've been hearing this week are long-term programmatic ideals. Very, very important. If we've been giving this session a few years ago, we would all be talking about 3-year and 5-year contracts. These have to be 10-year, 5-year agreements at the minimum. So it's very, very important to get things right and to have measures within the contracts where you can reevaluate on the highest level to make sure that they continue to be serving both parties. Serving both parties, that's important.
So Heidi, when you start seeing these signs that you mentioned, what can you do to intercede to change the direction?
I think for me, it begins with quality. So, both quantitative and qualitative. So, what is it that is, bubbling up? So one clinic that recently was really having some difficulties was at a school district in the Twin Cities area. And, it was post-implementation, a lot of turnover with the clinician. We switched the clinician, then we lost the MA, switched the MA. It was, the account team switched. It was one thing after another. And so we really did have to reset everything. And it was a go or no go conversation at a certain point. So we really did kind of a SWOT analysis and said, okay, what are the issues? What's behind the issues? How will we know if we're tracking well? And we really went to the source of, who we're trying to serve, which was the members, and we broke them into subgroups. So we interviewed, one set of interviews went to people who were clinic users and continued to use the clinic. We wanted to know the people who were using the behavioral health line, the medical line, what's working, what's not working. We asked the people who never use the clinic, what is it about, what's keeping you from using the clinic? And then we asked the people who were once using the clinic and who stopped. What is it about the clinic now that has kept you from coming back? So we used that qualitative information that was really impactful. That's what kept the district from closing the doors, because there was enough interest in those comments to say, yeah, it's important to us. We just don't like that there's so much change. So then we rolled up our sleeves and we worked with the vendor to do a complete quality improvement project on this vendor and employer relationship, because to your point, it really did rely on both of them to coming to the table. And we set up metrics for both lines of business. We said, how will we know it's improving? And switched out how things were run, listened to the comments we got from the members. And now, I will say, where it was at a D, it's now at probably a B+. But that was about 9 months ago, so it was worth it.
How about you, John? In your experience, what can you do to change the situation and make it better?
Change the situation for the client and innovation. I think for us, we have pretty strong partnerships with our clients. I think when there is some change in leadership, there's change in client contacts. When there's turnover there, it's always about re-educating and helping them understand why they began the clinics to begin with. It's very interesting that we're very mission-based. We understand the value of our clinics, But as new people come through, HR and benefits leaders aren't always aware of the benefits of the clinic. And so it is a constant re-education process, and us, letting them know the value that we bring, not that we're trying to be exorbitant and we don't have unrealistic ROIs or anything like that. We just really want to demonstrate that these are all the things that we're doing. Like, let's go back to our why. I mentioned a lot yesterday, and let's remember why we're doing this to begin with, why we came up with this partnership, and try to keep that footing at the front of mind.
Thank you. So Mike, let's go to the worst case scenario. The clinic's going to close. What's the post-failure clinic scenario that's created with this partnership? What's the next steps?
We, of course, think you hire expensive consultants. But if the clinic is going to actually close, and we brought in when clinics have closed a week after everything is gone, and then you have to reconstruct in a damaged situation, damage to the employees, damage to the firm, damage to the reputation of the vendor partner. So that's to be avoided at all costs. Normally, if something is about to close, or you have some understanding that it is going to change or transition for whatever purpose, you've got to preserve as much of the clinic services as you can, and you've got to preserve the status of the employee relationship with the employer, because you're going to have to repopulate that clinic with a new vendor partner or with a new service line in order to make your healthcare benefits program continue undamaged, let's put it that way. And many times that means that you've got to preserve the medical records, you've got to preserve some of the providers, they may have restrictive covenants, you've got to preserve some access points, perhaps some lateral contracts with different providers or different services. Virtual care is the one thing that comes to mind immediately, especially after this last session. So all that stuff needs to be done, and it is a huge project that's very costly and very damaging to all parties involved. I'm part of the costly piece of it, but the damage a lot of times can't be avoided.
Heidi, what do you communicate to employees, particularly if you're planning on reopening the clinic or switching clinic?
So, one example I would give, one of my clients has been very purposeful about how they brand their clinic, and I'm sure they're not alone in this, but they never brand it with a vendor's name or logo. And they watch their contracts to never include non-competes. So if they really like a provider or any team members, they keep the team members, they keep the branding at the clinic. It never seems to change, even if the vendor switches out from the back door. So in that case, there was very little disruption, of course, for the member, because everything seemed the same, even if operationally things were changing. So that's probably the least disruptive situation you can have. Another one of my clients was a different school district with a clinic that they switched out one vendor, and they were very intentional about it. Of course, with the district, you can do things like this. So they ended the relationship in May, and then they switched out the clinic, brought in the new team, and they opened it up in September. So they usually see quite a bit of a dip of utilization over the summer anyway. But they had to communicate, what medications are you on? Which pharmacy would you like those switched to? Would you like your records to be transferred to another PCP? Otherwise, we're going to transfer these records to this new care. All of those transition things, we had to keep very careful watch over, because the place they were leaving, the clinic they were leaving, that vendor wasn't going to be, on top of all of that. So that was really my responsibility to help them with my team.
Gotcha. So John, from a better perspective, when you're taking over a center that had failed, what do you need to do, either from your perspective or working with the employer?
So I really have to identify the root cause. Why was this clinic struggling to begin with? Was it the previous management? Is it the provider? Is it utilization is the benefit plan design. So coming and partnering with the client to say, these are the reasons that we feel that we're struggling. And if everything stays the same, we may not be able to actually fix it. We have to find the root cause. We have to fix that problem and be able to move forward together. And so we really try to partner, counsel our clients to say, this is how we feel we're going to be able to have a successful clinic in the future. And maybe that is sometimes changing out the provider, because that seems to be the root cause. Or your benefit plan design really has way too many barriers. You have a $40 copay to come see us, to come see your clinic, but you have a $20 copay for urgent care in the community. I mean, that doesn't make any sense. And so, of course, you're not going to have utilization in your clinic. And so, walking through that process, the implementation team that we have goes step by step, and we hopefully, when we open up the clinic with the quad running it will be able to take off and be very successful for that.
Thank you. All right, so last one question, Mike. So what do you recommend we do to avoid failure? For failure of the center, what should an employer do to avoid?
Well, before they fail, they should really look inward and understand why they were failing. We've got several examples where we've been called by employers because they were anticipating failure, and we found that the vendor partner was actually doing a very reasonable job, but nobody at the employer level was reading the reports, understood the reports, and internally took the reports to top management. It was more than a qualitative issue, it was a financial issue, and anticipation of cost reduction was not really well defined. So it's complex reports. I get it from my own people that, Schwab sends me a 60-page report to tell me that they didn't do as well as the market. I just want page 77. That's all I care about. That's all I can't get to it. So I've got tons of data, no information. So you've got to make sure that you're not dealing with a failure that's due to something that's going to just be easily resolved. The other, John mentioned it, released firing a doctor that's in charge of the clinic. That's another common thing that we've gone in to do to address. We said, gee, this is all wrong because your provider staff, one or two, are just wrong for this place. And the vendor as well as the employer both know that, but they don't have the tools to discharge and replace. And so once you identify, you say, gee, if you just fix that one issue, or that one personnel issue, and help these people find their true meaning in life, because it's not here. You would be able to have a good working relationship. So if there's a way to at all avoid this, you're going to be avoiding tremendous problems with all sorts of other issues. If it actually does fail, then you've got to go out really quickly to the vendor community and find someone flexible enough to come in and help you, or you're going to have to backfill with locums and close the clinic for a couple of weeks, or maybe a month. I'm not familiar with closing it for like 6 months, because then you've got a total breakdown and loss of employee commitment to this program and this idea.
I just want to reiterate, we've mentioned a few times providers not making it fit. That's really rare. I mean, that is not something that we see on a very frequent basis. It does happen at times, but that's not, we're not mentioning it a lot because it's a very common thing. Most primary care providers do really well in an on-site health plan.
So John, what is the major reason for this?
Well, I don't see a lot of clinics fail there. I mean, if you want to talk about success, you can talk about that all day long, but no, I mean, I do think that is one of the reasons is the clinic failures are too. But again, that buy-in process, the incentives, all the things we mentioned before, they all play into it.
And what do you think is, one or two things employers should monitor, if nothing else, to make sure they're on track?
And as far as monitoring provider satisfaction and utilization are the two main things I think you should be looking at, because those are the early warning signs that if utilization starts dropping off, there's usually a reason for it. And then really keep watching those quality scores. Can't reiterate that enough. Maybe not a sign of clinic failure, but quality of care and population health declining is not a good sign either.
Heidi, final recommendation?
Yeah, I agree with what John just said. The other thing I would add is the scores are important, and then looking specifically at the comments. Some of the comments can be quick fixes, like nobody answered me after I left a message. The clinic isn't open at 9, they didn't open the door till 9:20. I mean, little things like that add up, and, like somebody said yesterday, they go back to their desks and they tell 8 people. So, reputation matters.
Great. Any questions from the audience? Any experiences you want to share? All right, everyone's kind of drained. I appreciate it. Thank you all. Let's thank our panel for. Thank you all for